but this is part of a series of talks that we're doing at Bristol Menopause, just to help women understand more about what's happening to their body, helping to empower them around managing their consultations with medical professionals. So I'm Dr. Daniela Calandrini, as Tia explained. I'm one of the women's health specialist doctors at Bristol Menopause. But when I'm not here, I'm also an NHS GP. And so a lot of what I do involves seeing women with women's health problems. And in addition to that, I also fit coils, which I've been doing for about 14 years now. And as we'll talk about, one of the options for managing heavy periods is the coil. So hopefully I can give you a bit of insight into that. And we really wanted to do this talk because we know that women are used to putting up with lots of different things. And heavy periods is just one of those things. And we really want you to understand that you don't just have to put up with this. So 1 in 20 women between 30 and 49 will go and see their GP because of heavy periods or problems with their menstruation, the other word we use for periods. And heavy periods also make up about 12% of referrals into the hospital to the gynecological services. So it is a really important problem. And I guess I feel I'm more aware of this at the moment because my 13-year-old daughter has just started her periods, and having to sort of guide her through that, and it just makes me even more acutely aware of what we have to sort of put up with. And so I'm really keen that women really understand what's going on for them. So probably first of all, it's worth just talking a little bit about what happens in a sort of normal period. And I guess I've put it in those sort of inverted commas because what we all know is that every woman is individual, and we all have our own individual experiences of what we see with our periods. But in terms of research and studies that are done on periods, there does have to be a defined sort of normal. And so typically what's happening during a menstrual cycle is that there are changes in hormone levels that then have an effect on the womb lining, or what we call the endometrium. So if we think about the first day of your period as day 1 in this cycle, what typically happens during that time is that the lining is shed, and that usually lasts between 5 and 7 days. And then during that time, you get a sort of increasing level of estrogen built up to a peak. And then at that peak, you ovulate. And that's middle of the cycle, which typically would be around day 14. And then after that peak of estrogen, you get a sort of build-up of progesterone in the second half of the cycle. And that's the part of the cycle that we sometimes call the luteal phase. And it's that second half of the cycle and the changes in progesterone that often are linked to the symptoms of premenstrual syndrome that women can get. So often they can feel other symptoms at that point in the cycle. And then if the egg is not fertilized, then the progesterone level drops, and the endometrium that's gradually been building up is then shed, and then you will have your next period. And so normal for the case of research suggests that it would last about 5 to 7 days, occurring on average every 28 days. And women tend to lose between 2 and 5 tablespoons of blood a month, so about 30 to 80 mils of blood. However, what we're thinking about here is something called heavy menstrual bleeding, or HMB for short. And that's when women are not experiencing what we would describe as typical. And what's really lovely to see that NICE, who are the organisation that help us with a lot of our guidelines, have moved away from thinking about the amount of bleeding that you're having and moving much more towards the sort of impact on your quality of life, which really is where we want every woman to sort of be thinking about when they look at all symptoms that they have. And really, if you can answer yes to any of these questions in this slide, then you would reach the threshold of a diagnosis of heavy menstrual bleeding. And 70% of women will not have heavy periods, but that does mean that 30% will. And sadly, of those 30 and 100 women that have heavy periods, only 5 of them will go and see their doctor. So what I'm really keen to do from today is make sure that people understand whether they've got heavy bleeding, and then they feel empowered so that more people can go and talk to their doctor about it and understand what to expect, and also what sort of treatments that could be on offer. So what we've talked about so far is the heaviness of the bleeding, but the other important aspect is to think about what is abnormal bleeding. And I mentioned my daughter before starting her periods, and what I was really pleased to see is that, as well as sort of very excitedly dashing to get her period pants for her period, she also dashed and got her phone. And I think this is something that I am seeing increasingly in consultations, that women are getting much better at charting their periods. And I think that is really helpful when you go to see a doctor, to really understand what's going on with your periods, because not only does it give us an idea of when you're having your period, but it also helps us pick up any issues that you might be having. And that falls into this category of abnormal bleeding. So, for example, sometimes women can have bleeding in between their periods, and that's what we call intermenstrual bleeding. And that can be a sign of some certain causes for the bleeding. So some infections, so sometimes things like chlamydia can occur with bleeding in between their periods. Some women get bleeding after sex, or what we call postcoital bleeding, and that can sometimes indicate that there are issues with the cervix, and so that there would need to be an examination of the cervix. But also other symptoms that can go with your periods. So what are your periods painful? And if they are painful, when are you getting that pain? So conditions like endometriosis often typically will have pain just before their period, and then the pain will improve when they bleed. And endometriosis, if you're unaware of what that condition is, so we describe the lining of the womb, that's also known as the endometrium, and that is what is shed in a period. But in endometriosis, you get pockets of this endometrium, not just in the womb, so in abnormal places, for example, on an ovary, on a bladder, or on a bowel. And so when you bleed with your period, you also bleed from those places, and so it can be very uncomfortable. So pain associated with the bleeding can also be a useful information to have collected. And then finally, other situations like when women have finished their periods, so when they've become postmenopausal, so gone a year without periods, if they have bleeding after that, then that is considered abnormal. And likewise, a lot of women we see here at Bristol Menopause are using HRT to manage some of the symptoms of the menopause. And we need to understand whether the bleeding that they're experiencing is to be expected for the type of HRT that they're on, or whether that's abnormal and needs to be investigated. So I would really encourage you all to, if you're not using an app to chart your periods, to start doing that, because that's really helpful information. So I just wanted to think about what the causes of HMB, or heavy menstrual bleeding, often are. Well, unfortunately, in 50% of cases, we cannot find the cause. But that doesn't mean that we don't need to try, first of all. Often bleeding can be caused by an underlying medical condition that you may have. So disorders of the thyroid, either an under or an overactive thyroid, can have an impact on your periods. Likewise, diabetes, having issues with your kidneys or your liver, can cause problems with periods. And then the other example is that a lot of patients who have issues with clotting can have heavy periods. So there's one particular condition that actually is quite common called von Willebrand's disease, which means that your blood doesn't clot properly. But it goes undiagnosed because often the first time that people will present with it is with heavy periods, and sometimes that's not taken seriously. And then the next time is when they go to the dentist and they probably bleed excessively, and then someone does take that seriously and they do the test for von Willebrand's, and then they ask, what are your periods like? And you find out that women have been struggling for a very long time. So it can certainly be linked with other conditions. Some medications can affect your periods. So obviously things that make your blood thinner. So people that are maybe on a drug called warfarin that makes your blood thinner can result in heavier periods. Some of the things that stop your blood from clotting, so things like aspirin. Some of the anti-inflammatories that you may be using as a painkiller. So often things like ibuprofen can have an impact on your periods, though sometimes we do use that to help with treatment. And other things like antidepressants can affect your periods. Supplements that you might be taking can affect your periods. And then sometimes women can have things like a coil. So the copper coil is well known to cause heavier periods. And then in addition to that, there's things that often are linked to periods. So things either within the womb or the ovaries that can cause the bleeding. So we talked about endometriosis and what that condition is, and that can be a cause of heavy bleeding. Its sister condition, which is adenomyosis, which you may have heard of, can also cause heavy bleeding. And in that case, you see some of the endometrial lining lying in the muscle of the womb. And you can either have no symptoms, but you can also get pain and heavy bleeding. But the other things that your doctor will be really keen to sort of think about is, could this be a sign of some of the cancers that can occur in this area? And sometimes you can get polyps in that area. And so depending on what we think is going on, depends on what we do next in terms of sort of investigations. So I wanted to just talk a little bit about what you should expect. If you have got this problem and you go and see your GP, you've decided that you want to try and solve this, what would you expect to happen from your doctor? And the first thing is really key is that you should expect to have a really detailed history. And that in part is where your app comes in, because you can give them all the information that's needed. And I remember when I was at medical school, we were told regularly that 80% of the diagnosis of any medical condition is based on the history. And the rest of the examination is really often to confirm what you may suspect. So they will likely ask you about the type of bleeding, the amount of bleeding, a little bit about your history of your periods to see whether they've always been like this or not, because a change in periods is a really important indicator that there could be issues with your periods. A bit about your medical history, so we can pick up some of those conditions that we've just talked about. But also, if women are bleeding really heavily, you can become anemic. And so you'd hope that there was some questioning around the types of symptoms that you're getting. So you might be feeling more tired, you might be feeling a bit more short of breath or a bit more dizzy. And so from all of that information, in most cases, your doctor will have a fair idea as to what could be causing your symptoms. And if you've not told them anything that raises concern, then it would be entirely appropriate just to get on with actually treating you. We don't need to put women through examinations if we don't think it's going to change the outcome. So some women will just start treatment. However, quite a few women will need an examination. And typically, the sort of examination that I would expect to do is, first of all, examining a woman within their abdomen, so putting hands on their tummy area to see if I can feel anything. So I typically describe that as feeling for any lumps or bumps that shouldn't be there. And some examples like fibroids, which can be a cause of bleeding, can get quite large. And on a few occasions, I've been able to sort of feel their womb up in their abdomen, a bit like they're pregnant. And so that gives me an idea that we may be dealing with something like fibroids. But the other part of the examination is often a pelvic examination, which is much more sort of intimate, and it would be absolutely expected, if you wanted to have a chaperone during that examination. And in that stage of the examination, your doctor would do what we call a bimanual examination. So they would place the fingers of one hand within your vagina and one hand on your tummy, and you're just trying to feel the organs between your hands to see if they're enlarged, and also just trying to understand if there's any pain. So sometimes you can have pain on a particular side that can point to certain conditions. And then after that, you may have a speculum passed, a bit like when you have a smear. You probably won't have a smear taken unless it is due, because the National Screening Programme will not let doctors take a smear unless it's due. They will just throw it away if you haven't been called for that. But if your doctor can see anything abnormal on your cervix, then they can refer you through an appropriate route to have that looked at. And then, depending on what they've found and what they're suspecting, the next stage could involve doing some blood tests to check for some of those conditions that we talked about, checking your thyroid, checking to see if you're anemic, and also checking your iron levels. We often find that sometimes women are not anemic, but they could well have sort of low normal iron levels, and having those topped up can often make them feel a bit better. And then the other examinations that you might expect to have is you might have an ultrasound, so a pelvic ultrasound, which is usually done with a probe vaginally. So it's worth sort of knowing what to expect. And in that, they can see how thick the lining of your womb is, look at your ovaries, and then look to see whether there's any signs of fibroids or maybe endometriosis. And in some cases, if you're concerned, for example, in a woman that has stopped her periods a long time ago and is bleeding, that you may be referred directly to the gynecologist to have something called a hysteroscopy, which is where they insert a camera through the cervix so that they can look inside and maybe also take a biopsy. So hopefully you've got a sort of fair idea of what your doctor's looking for. And then what I wanted to do is sort of explain how it can be treated, because it's all well and good knowing you've got this problem and having an idea what's causing it, but how do we make day-to-day life feel better? And I think the important thing to remember that this is a discussion. There's no point in us starting a treatment that a woman has either got really clear preference against, or something they've tried and had side effects from. So it needs to be a two-way discussion. And likewise, a few things. So if your doctor is suspecting that you may have fibroids, some of the treatments are potentially going to be more appropriate than others. So it starts finding out a bit more about what you were hoping for and what you've tried. But the NICE guidance would say first line for women with heavy bleeding is the Mirena coil. And a lot of women, sort of when I mention that, you get quite a clear reaction one way or the other as to what they feel about that. And I'll talk to you a little bit more about the Mirena coil, because I just want you to sort of be able to consider it a little bit if your doctor ever suggests that to you, so you understand a bit more. But in addition to the Mirena coil, there are non-hormonal options that you can take. There are other hormonal options, so pill options. And then there are some treatments that can't be managed in a setting like ours or your GPs that have to be managed by the gynecologists. And this probably isn't in the remit of this talk to talk a lot about these, but just so you've got a little bit of an idea of some of the terms that you may have heard mentioned. So, for example, if a woman has endometriosis as the cause of their bleeding, they can try all of the treatments I've talked about, but they might be referred on to the gynecologist for one of these treatments called the GnRH antagonists. And what they do is they work to turn off the ovaries, because we talked about this abnormal lining being stimulated and causing pain. And so if you can turn off what's happening in the ovaries, you turn off that stimulation. And for some women, these drugs can help solve that problem, or for other women, it's giving them an idea that if they had their ovaries removed, what it would feel like. So that's one treatment that the gynecologists sometimes think about. There's also endometrial ablation. So the idea is that if you are bleeding from the lining of your womb, if we can get rid of that lining of the womb, then that often can help. And they can do it in lots of different ways. They can use radio waves, they can use a warm balloon to sort of burn it, or they can use microwaves. And that can be done as a local anaesthetic procedure. But it isn't great if you want to have more children, because it can affect that. And it's not great for fibroids as a treatment. And that leads me on to the other thing that's mentioned there. So uterine artery embolization, which can be used by the gynecologists. And that's particularly good for fibroids. And you can see sort of about a 40% reduction in size of fibroids with that treatment. It's actually done by radiologists who put a little catheter into the artery that supplies the blood supply to the fibroid and clots it off, so it no longer is fed by the blood vessel, and that can make them shrink up. But again, that isn't a good option for women that want to have children. And so most of these treatments you'd come to if you had tried a lot of the other treatments. And finally, hysterectomy. The gynecologists used to do loads of those, but with the advent of the Mirena coil, they're really not doing many of those now. That has made a massive difference to that as an option of treatment now, though some women do still need it. But what I'm going to focus back on now are the treatments that you would expect your GP to offer you, and things that are available in the community, either with your GP or here with us. So some women don't want to use hormones, and going back to us talking about what has worked for you and your experiences and what you want to try, that's where this becomes really important. So of the non-hormonal options, you can actually reduce the bleeding by up to 50%. So they're not to be discounted at all. So one example is something called tranexamic acid. And that works on helping the body to clot so that you end up with less bleeding. So all those blood vessels that are feeding the lining of the womb that you shed during your period, if we can get those to clot off quicker, the amount of bleeding you see reduces. The tablet is taken when you start bleeding, and usually for up to 4 days. It's generally quite well tolerated. Some people can have a little bit of an upset stomach with it, and it isn't suitable for people who have a higher risk of bleeding. And then also there are the anti-inflammatory medications. So those are things like mefenamic acid or naproxen. So those are things in the same family as ibuprofen that can reduce something called prostaglandins, and they can help reduce the amount of bleeding that you have. And then we think about the hormonal options, which most women are often sort of a bit more aware of because they may have been tried in the past. So there's the combined contraceptive pill that can be used to manage periods. That contains both the estrogen and progesterone within it. Traditionally, you would have taken that for 3 weeks of the month and then had a week off where you would have had your period. But nowadays, we're moving towards sort of more tailored regimes, and we do something called tricycling. So what you can do is run 3 pill packets back to back and then just have a period once every 3 months. So for a lot of women, they can cope with their periods if they're not having it as often, and that can work really well. Some women, though, the combined pill is not appropriate. So if you have migraines, if you are older, so if you're over the age of 50, or if you have a higher BMI, that pill might not be appropriate. And you can have the progesterone only pill. And typically those pills stop you from ovulating. So a lot of women will not generally bleed with that pill. And so that can be a good alternative. And then finally, there's the drug Provera that can be used. Now, most commonly, that is the drug that can be used if women are going on holiday and they can cope with their heavy periods most of the time, but if when they're on holiday, that's a problem. You can use Provera to help postpone your period to a time where it would be more convenient. And rarely it can be used as treatment for some of the conditions like endometriosis. The other thing, though, as I mentioned, is the Mirena coil. And I just want you to just consider that actually there's a lot of noise out there on social media around coils. And I've been fitting coils for a long time. I've been fitting them for 13, 14 years now. I've also had 2 coils myself, and it has been brilliant. So I have not had a period for about 12 years. And it was particularly relevant for me because after I had my children, my periods were a lot heavier. And so this has been the solution for me to really try and manage things. It contains a hormone called levonorgestrel. What a lot of women find is that when it's first put in, the way that it works is that it thins back the lining of the womb. So you shed the lining that's there, and then it stops that lining from reaccumulating. So when it's first put in, you do get irregular bleeding for the first 3 to 6 months as you shed that lining, and it gradually lessens over time. But a lot of women will find that after 3 months, their amount of bleeding has reduced by about 90%. And then when they get to 6 months, it's reduced by about 96%. So it is really effective. The other beauty of the Mirena coil is that it can help in other situations. So it can be the progesterone part of HRT. And it also is a contraception. So it can help with your periods, but it can also help with other aspects of life. And how long you can have it for depends on why you're using it. So it now can be used for 8 years for contraception, and it can be used for 5 years as part of HRT. It also has a license for 5 years for heavy bleeding. But if you get to 5 years and you're not bleeding, you can just leave it in if you don't need it for your HRT. And so it is a really effective way of treating periods. Now, a lot of women wonder what it involves. So when a coil is fitted as standard, we would ask you to take some pain relief in the morning. I use either a local anaesthetic gel or I use a spray to sort of numb your cervix. There's no needles involved with that at all. You would have a speculum passed, and often we have someone with you in clinic who will just be holding your hand when you're going through it, and that often just distracts you. And then the coil is placed, so it's passed through the neck of the womb and opened. And the pains feel a bit like a sort of period pain, I would explain. It's a really odd feeling because it's a pain in an area that you maybe not have experienced before. But I would just encourage you to sort of think about it. And famously, Davina McCall had her coil fitted live on TV. So there's a dispatches programme where you can see her having it fitted. And what I hope you'll realise she doesn't lie about that. There is a point where it's a little bit uncomfortable, but she's able to talk quite openly throughout the consultation while she's having it. So hopefully it's something that you would consider having done. So I guess my key messages for you are that heavy periods are common, but you shouldn't have to suffer with them. If you are struggling with this is something that you need to go pre-armed with the information, but I really want you to go and chat to someone because there's so many options out there. And yes, in 50% of cases, we don't find the cause, but you can still try all of these treatments. I want you to go and chat to your GP about what you're experiencing. And also, please don't discount the Mirena coil because it's a really good option for a lot of women. So thank you very much for listening to me on this wonderful day. And I'd be happy to sort of answer any questions at all.
Thank you, Daniela. That was great. Does anyone have any questions at all? If you do, please pop them into the chat. We'll wait a few minutes, see if anyone's got any questions. They'll all be asked anonymously. See if anyone's typing a minute. There is someone typing, so we'll just wait a moment. A couple of people typing. You obviously covered everything, Daniela. So one person said, very fair and no questions from me, thank you. So we'll wait and see if someone else who's typing's got a question.
Thank you.
Still typing by the looks of it, it's few people typing. Someone else has put very, very useful session. Thank you. No questions from me. So there's a couple more typing. So see if any of those have got any questions. Right now they're going to test me in pronouncing the words. Just to put out there, I'm not medically trained, so I'm not sure if you can see the questions. Daniela.
Yeah, I can see the question.
Yeah, so, just yeah, you'll be able to pronounce the words better than me.
Yeah, so
Grill.
Yeah. So we've just been asked a question about what we do at the clinic about changing. So if you were to change from a particular sort of oral preparation HRT over to the Mirena coil, could we do that in one appointment? We'd ask actually for 2 appointments, one to change the coil for you and one to review your HRT, and probably to review your HRT first of all, just to make sure that having the coil as part of your HRT is the most appropriate treatment for you. And then if that is the most appropriate treatment, we could then go on and book a coil replacement and change. So that could all be done in one appointment for you. The change.
Okay, yeah, so just following on from Daniela, so if anyone did want to book in an appointment for coil, you can do that as a singular appointment. However, if you did want your HRT reviewed, if you're already a patient with us, you can schedule for a follow-up appointment. Or if obviously you're a new patient, you just need to book in for an initial menopause appointment. And there's another question come through. It says, every time I go to the GP for my heavy period, the doctor always dismisses me or puts me on the combined pill to get around this. Do I just ask for the coil?
So thanks. So I think the first thing I would say is I would find out a little bit about your GP surgery and find out if there is anyone that's got a particular interest in women's health. So there usually is at least one or two doctors that have an interest, and hopefully they'd just be a bit more open to talking about your periods in a sort of more approachable way, because as we've sort of shown, there's lots of different treatments out there. But the Mirena coil is a really good option. Not all GP surgeries will fit it, so that might be why they're not offering it straight away, but they should be able to refer you on to see someone to have that fitted, even if they don't do it themselves. And like Tia was saying, we also fit them here, so if that was something that you wanted to do, that's something we could do for you too. But I would just find out who has an interest. That would be my top tip. So as you can probably imagine, in my GP job, I spend a lot of time doing women's health because the word's got around.
Daniela, is the video for Davina not working?
Sorry, say that again.
The video for Davina, is that not working?
I thought it was just a picture. I can copy the link into somewhere.
Yeah, it should be playable. It's not playable my end, so I didn't know. So a lady just asked if the coil fitting painful, so I thought that obviously be a perfect for someone to see her having it fitted.
Yes, it would. I wonder if I can try and share it a little bit. Let me see what I can do. Just to see if I can get that up there.
Yes, I think it'd be good for obviously everyone to.
Yeah, let me just see if I can get that.
If you can, I can try and do it at my end. So we're just going to try and get the video for you ladies to see of Davina herself having her coil fitted, so you can see what it entails and obviously her experience.
I might have to stop sharing my screen a second of this. And then,
Yeah, that's fine.
Yeah. I'm struggling a little.
Thank you very much for your lovely comments, Jacqueline, really appreciate it, and we're glad that we could help you and support you. We look forward to welcoming back to the clinic soon for your follow-up as well.
So is that sharing now?
Yeah, if you just click on it to start, it should show up, but yeah, we can see the screen.
Can you hear that?
No, so the actual video is not playing.
Oh, it's playing my end. What I might need to do is I could put the link in, that we could put the link in the chat so people can.
Yeah, I think that'll probably be best, and
yeah, let me do that.
And you can all watch it in your own time then without any technical difficulties.
Yeah, I'll get that popped in. I'll stop sharing. Give me a second.
Does anyone else have any other questions at all before we finish today's webinar? We do have a few more webinars coming up. So if you always just keep a lookout on our events page on our website. So our next one's on menopause and perimenopause and mental health. So please do check that out on our website. It's another free webinar. We also have a free webinar around bra fitting and breast health up and coming. And we've also another free event we've got coming up. It's actually next Wednesday. Women's walking rugby in collaboration with Bristol Bears at the rugby club, which is also on our website where you can register your interest in that as well. But any questions at all, do please ping them across and we'll support you where possible. And again, thank you so much, Daniela, for sharing your knowledge today. It's much appreciated. Obviously, this session has been recorded, so it will be going on to YouTube, but also we'll get the link across to everyone that's attended today so they can watch it back if needed. Thank you, everyone, and thank you, Daniela, for joining them.